All right, great. Hi, everybody. I'm really excited to welcome you all to the Circulation Cardiovascular Imaging webinar. As you know, we'll be discussing the recently published AHA scientific statement, State-of-the-Art Imaging of Infiltrative Cardiomyopathies. Dr. Kaz Negishi and I are the digital media strategy editors for Circulation Cardiovascular Imaging, and we're really excited to have key authors of this document share their knowledge with us today. We have three authors, including the chair and vice chair of this document. They'll talk to us about key concepts in this document. This will then be followed by a discussion, including a question and answer session towards the end of the presentation. Please go ahead and do submit your questions to us, and we will get to them at the end of all three talks. Without further ado, I'll turn it over to Dr. Negishi, who has a few questions for Dr. Gropler, who's the editor-in-chief of Circulation Cardiovascular Imaging.
Thanks very much, Jiwon. Hello, everyone. I'm Kaz Negishi from Sydney. So it is my great pleasure to host you for this webinar. And I'd like to ask some questions to the Dr. Gropler. He doesn't need any introduction, but he's as the Jiwon said, he's the editor-in-chief of this journal, also the senior vice chair and division director of the radiological science at Garcia in St. Louis. So Dr. Gropler, could you provide us some background in terms of the rationale of this AHA scientific statement, please?
Yes, thank you, Jiwon. Thank you, and I want to thank all three speakers, Kate, Hanneman, and Mario, for joining us today. And yeah, this paper, it's an important one. It comes out of the Cardiac Imaging Committee, which represents members from both the Clinical Council and the Cardiovascular Radiology Interventions Council, with a liaison from several other councils in our journal. And this council is critical for providing information and understanding of where imaging fits within cardiovascular medicine. And it has many roles, but one of the major ones is in imaging and applications thereof, and its education. And what's fascinating about cardiovascular imaging now is that it's growing so rapidly, it's redefining how we take care of patients, and that it's identifying totally new diseases that we didn't pay attention to for years. Cardiac amyloidosis, sarcoidosis, things like that you'll be hearing about today. And one of the ways that it's done is through commissioning scientific statements such as this that are then vetted all the way through the very elegant and detailed process at the AHA. And so this was one of the topics that was generated by the committee. Dr. Garcia was a previous chair of the committee. Dr. Kottam is the current chair of the committee, I believe, until June. And so, it covers an area that has grown in our understanding in the past few years, and we thought needed to be positioned as to where it is currently. And I suspect will be outdated within 3 years based on how rapidly the world is changing.
Thank you very much, Rolf. It was great to know that. So we might looking for the new version in 3 years' time on this, which is also exciting.
No pressure, guys.
Right. So we might move to the main part of this webinar. So I'd like to take the honor to introduce the Dr. Mario Garcia. Just before that, we would like to, audience to put feel free to put your questions in the Q&A boxes and at the bottom of the screen. And then at the end, we will pick up some as far as the time allows. So then allow me to introduce the Dr. Mario Garcia. So he also doesn't need any introduction for the He's the chair of the cardiology at Montefiore Medical Center in the Albert Einstein College of Medicine, and also as Dr. Gropler said, the vice chair of this scientific document. He will be talking about the imaging approach to the infiltrative cardiomyopathy. And I'll pass it to you, Mario.
Thank you very much, Kazuaki, for this kind introduction. I'm gonna share my screen. And thank you, Jiwon and Robert, for inviting me to participate in this forum. It's an honor to share with Kate and Anupama this important topic here. I think you're relatively optimistic if you think that we can wait 3 years for things to get to change in cardiac imaging. 3 years is an eternity. I think we can throw away everything we learned before COVID and think more in the terms of how things change month by month. So I will basically do a brief introduction, and I want to start by saying that this is a topic of very, very much interest for everyone in my faculty here at Montefiore. So the infiltrative cardiomyopathies are diseases that are characterized by intracellular or extracellular myocardial deposition of abnormal substances that gradually results in systolic dysfunction, diastolic dysfunction, or both, and can lead to heart failure and death. Infiltrative disorders amount for up to 5% of all cases of new onset heart failure that is unexplained at the time of initial presentation. On imaging studies, infiltrative cardiomyopathies may appear with increased wall thickness and normal or reduced left ventricular cavity size, such as is in the amyloidosis, Fabry's, and the mucopolysaccharidosis. And they resemble phenotypically hypertensive heart disease or hypertrophic cardiomyopathy, which are mainly conditions that we have to entertain in the differential diagnosis. There are others such as sarcoidosis, Wegener's, and hemochromatosis that actually may present with a predominantly dilated phenotype and a reduced ejection fraction at onset. And they actually mimic more dilated or ischemic cardiomyopathies. The intracellular or extracellular myocardial infiltration actually causes inflammation and fibrosis that eventually leads to impaired myocardial function, increased mechanical stress, microvascular dysfunction, and decreased coronary flow reserve. This particular case is a young woman who presented here to our hospital with past known history of SLE, and she was admitted with rapidly progressive heart failure, which rapidly turned into cardiogenic shock. You can see that at presentation, her ejection fraction was markedly reduced, and she had a mobile apical thrombus. Abnormal diastolic function with reduced ventricular compliance is almost universal and may be the initial abnormality detected by echocardiography. A restrictive filling pattern evident by a short acceleration time indicates usually a decreased left ventricular compliance as predictive of poor outcomes in most of all of these conditions. In our particular case, myocardial biopsy, remember our patient had a history of lupus, was able to actually reveal the presence of increased vacuolization, which was consistent with the diagnosis of hydroxychloroquine toxicity, which is a type of toxic-induced cardiomyopathy. However, I must say that contrary to what we once thought, in many patients, myocardial biopsy is unrevealing. This is a large series from the Cleveland Clinic of consecutive patients who underwent cardiac biopsy, in which heart failure associated with unexplained restricted cardiomyopathy was labeled here as number 6, the main indication for biopsy. Of 286 biopsies, these were only diagnostic in 29% of the cases and resulted in a change in management in only 25% of time. These are all the patients with restricted cardiomyopathy suspected to be infiltrative in origin. So alternative, we use non-invasive cardiac imaging, and right now it has become the reference standard for evaluating morphology and function, determining a specific etiology, stratify risk, and guide and evaluate response to therapy. Echocardiography is often the first-line evaluation for the assessment of cardiac structure and function and for serial assessment given its safety and cost-effectiveness. Analysis of local myocardial dynamics, including Doppler, tissue Doppler, and speckle tracking, allow for quantitative assessment of subclinical myocardial dysfunction. And alterations in left ventricular and left atrial strain may have be used as surrogates of invasive hemodynamics, and are strongly associated with reduced event-free survival. Computed tomography has limited applications in comparison, but in selected patients may be useful to exclude ischemic cardiomyopathy. CMR is an important non-invasive imaging modality to establish the specific diagnosis and risk stratification of patients with infiltrative cardiomyopathies. In addition to the evaluation of myocardial perfusion and fibrosis with gadolinium contrast, T1 and T2 mapping over the last decade have increased the sensitivity and specificity of CMR, reducing the need for additional testing. The presence and extent of abnormal CMR findings, such as late gadolinium enhancement, is associated with adverse cardiac outcomes. A comprehensive assessment of the role of CMR will be covered in detail by Dr. Hanneman next. Nuclear scintigraphy techniques allow for determining the disease activity and are a promising tool to assess response to therapy. A detailed overview of the role of echocardiography and nuclear imaging will be covered next by Dr. Kottam. However, imaging findings need to be interpreted in the context of clinical presentation, serology, and genetic testing, since different conditions may have similar imaging characteristics, such as in this patient who actually have Chagas disease, but exhibit imaging characteristics that were undistinguishable from cardiac sarcoidosis. So stepwise diagnostic algorithms have been proposed that integrate clinical, echocardiographic, serological, and imaging criteria. Their implementation in the evaluation of specific infiltrative disorders have been covered in our recently published scientific statement, and we will be discussed in greater detail by Dr. Kottam and Hanneman following this presentation. Thank you again for allowing me to make the introduction to this topic.
Thank you very much, Dr. Garcia. That was the fantastic overview of the today's topic, starting with the very young lady case with this based on the SLE and the cardiomyopathy, and an overview of the multimodality things, starting from echo, CT, MRI, and so on. And that was definitely seen correctly. And I will hand over to you, Jiwon, to the next speaker.
Wonderful, wonderful talk, Dr. Garcia. It's my honor to introduce Dr. Kottam, who is an associate professor at Baylor College. She's also the chair of the scientific statement, and she'll talk to us today about echocardiography and nuclear imaging in infiltrative cardiomyopathies. Welcome, Dr. Kottam.
Thank you, Dr. Kim. It is an honor to be here today and then to be presenting this topic that was on a paper that was recently published. I'm going to share the slides. Thank you all for joining today and for this opportunity to present today. So my topic is going to be on the use of echocardiography and nuclear imaging in infiltrative cardiomyopathies. First, I'd be talking about echocardiography and then subsequently nuclear imaging. As you all know, echocardiography is the first imaging modality in any patient with clinically suspected cardiomyopathy, not specifically infiltrative cardiomyopathies. With echocardiography, we are able to assess the morphology, systolic function, diastolic function, and also myocardial deformation and dynamics, local dynamics, by using tissue Doppler and speckle tracking techniques. Specifically in the evaluation of cardiac amyloidosis, the morphological characteristics take an important role. And as you can see, there is increased thickness of the left ventricular myocardium. There can be thickness of the right ventricular myocardium. Left ventricular systolic function can be relatively preserved, and the cardiac chamber can also be normal in most cases. And biatrial enlargement is also a common feature. Often seen is also small pericardial effusions. The same thing reflected on the other image also. And as these morphological features raise suspicion for cardiac amyloidosis, that can be further confirmed with diastolic dysfunction that is seen on tissue Doppler imaging. So mitral inflow in this particular image shows a predominance of E wave, and the deceleration time is short, less than 120 milliseconds, suggesting a restrictive filling pattern. That, coupled with impaired tissue Doppler velocities, here markedly reduced to less than 5, suggests that the myocardial relaxation is abnormal. The E to E prime ratio is elevated, suggesting that there is elevated left ventricular filling pressures. So further, when tissue Doppler, when speckle tracking is performed, we see a predominant apical sparing pattern, also called as a cherry on top pattern, where there is basal and mid ventricular segmental attenuation of strain, and then apical strain is relatively preserved. This finding is highly sensitive and specific for cardiac amyloidosis, and predominantly is based on several theories have been proposed, but one of the theories is the decreased amyloid mass, total amyloid mass in the apex when compared to the basal and mid segments, causing sparing of the apex until the later stages of the disease. Next, talking about Anderson-Fabry disease and echocardiographic applications. The typical morphological features in Fabry disease are thickened LV walls and also papillary muscle hypertrophy, as you can see here. And then the binary myocardial layer with a prominent or echogenic endocardial layer and not so echogenic or hypoechoic mid-myocardial layer, thought to be because of compartmentalization of glycosphingolipids. Glycosphingolipids or Fabry disease is a lysosomal storage disorder with accumulation of glycosphingolipids, predominantly in this binary pattern within the left ventricular myocardium. And coming to cardiac sarcoidosis, most of the cardiac sarcoidosis features are clinically driven, and echocardiography may not be as sensitive in making a diagnosis or raising clinical suspicion. But the features that are seen in echocardiography that should definitely raise a red flag would be thinning of the septum, as seen here, especially the basal septum, and one could see basal inferolateral thinning as well, scarring and thinning. The other feature would be papillary muscle dysfunction because of granulomatous infiltration within the papillary muscle, and presence of ventricular aneurysms. Here demonstrated is a basal inferior aneurysm, but multiple aneurysms can also be seen in sarcoidosis, and that should raise a red flag while interpreting echocardiograms. So echo findings in sarcoidosis can be limited, but whenever these findings are seen, then further testing is indicated. Now, moving on to radionuclide imaging, as far as infiltrative cardiomyopathies go, SPECT and PET imaging have taken wide strides in the diagnosis of infiltrative cardiomyopathies. And the use of radionuclide imaging, we are able to assess not only myocardial perfusion and coronary flow reserve through PET imaging, but also myocardial metabolism and inflammation, again with PET imaging. And in the past decade, bone avid radio tracers have significantly changed the way we approach the diagnosis of TTR amyloidosis. So in cardiac amyloidosis, bone avid radio tracers have been used. And here I have a picture of the stable TTR tetramer. TTR is a protein that transports thyroxine as well as retinoic acid in the bloodstream. It exists in a tetramer, which is a stable form depicted in 4 different colors here. But when, for whatever reason, the tetramer degrades, it forms monomers, and these monomers are aligned in a beta-pleated fashion, causing accumulation in various tissues. So the bone tracers such as technetium pyrophosphate and the other DPD and HMDP, they bind to the calcium or microcalcifications present in the TTR protein, and thereby cause myocardial retention. And when we image the post injection of the radio tracer, we are able to image the myocardium and see the uptake of radiotracer in the myocardium. This test is quite sensitive and specific for the diagnosis of TTR protein, and therefore has significantly decreased the need for endomyocardial biopsy for definitive diagnosis. Here I have two sets of images. The image A shows a normal study, normal PYP study, and then B is an abnormal or positive study. So in the normal study, what we see is that there is hardly any myocardial uptake of radiotracer. And when compared with the contralateral lung ratio, the ratio is 1. That suggests that there is no myocardial uptake. In addition to looking at planar images, it is highly recommended to look at SPECT images as well, so that we exclude any presence of blood pool concentration of the radiotracer. Here, obviously, there is no myocardial or blood pool uptake. That, again, confirms that this is a negative study. Whereas the image on the right-hand side, it shows significant myocardial retention of radiotracer. And when the counts are compared to the contralateral aspect, the ratio is 2.36. And visually, the grade is also severe, that is grade 3. That suggests that TTR is highly likely in this patient. However, just looking at planar images is not going to be enough because, again, blood pool localization of the tracer in the blood pool itself can give the same picture on planar images. This has to be confirmed with SPECT images. And here in the SPECT images, we have significant radiotracer accumulation in the myocardium, but none in the blood pool. That supports that this is true myocardial retention, and therefore this is highly suggestive of TTR amyloidosis. So the couple of things to pay attention to while interpreting PYP scans, as I mentioned, making sure that there is no radiotracer within the blood pool. And typically, the recommendation is to image 1 hour post injection of the radiotracer. And in those who have slightly delayed clearance of PYP tracer, a 3-hour scan can be attempted as well. So timing of acquisition is important. Reviewing of SPECT images to exclude myocardial blood pool involvement is important. The SPECT images also help us exclude any presence of focal myocardial infarction or focal rib fractures that also increase the bone tracer uptake, and also situations like hydroxychloroquine toxicity, which also results in increased uptake of the radiotracer. So also to keep in mind is that more than 25% of AL amyloidosis patients can show PYP retention milder to equivocal degree. And therefore, it is imperative that AL amyloidosis is ruled out with serum light chains as well as serum immunofixation electrophoresis. So not only that, also there are certain other certain mutations, such as early onset valine 30 methionine mutation, which does not uptake TTR protein despite being ATTR. Therefore, genetic testing is also imperative in patients with clinically suspected TTR amyloidosis. So that was about bone tracers and SPECT imaging, and moving on to PET radio tracers in the diagnosis of amyloid. There are promising several PET radio tracers that are being studied now. These are mostly thioflavin T analogs that bind to the beta-pleated motif of the amyloid protein. However, these are not shown to be very discriminative between AL versus ATTR amyloidosis. They are very helpful in diagnosing cardiac amyloidosis, but not so helpful in differentiating AL versus ATTR. However, one of the PET radio tracers, fluor-beta-ben, that has longer, higher affinity to AL fibers and therefore delayed imaging may still be able to differentiate AL versus ATTR, because radio tracer has been found for a longer duration in AL amyloidosis than ATTR. So further studies are still needed to confirm these findings, and also to look at different methodologies so that AL versus ATTR can be differentiated. Moving on to radionuclide imaging in cardiac sarcoidosis, the focus of imaging with radionuclide tracers or radionuclides is evaluation of myocardial metabolism. This in conjunction with perfusion and looking at perfusion metabolism mismatch will help us identify areas of myocardial inflammation. Other imaging modalities like MRI or hybrid imaging can also further help accurately stage the disease and then look at treatment response. So, but the main diagnosis of sarcoid is clinically suspected based on conduction system abnormalities or ventricular arrhythmias or unexplained heart failure in the absence of coronary artery disease. And PET imaging would help us identify active inflammation in sarcoidosis versus chronic sarcoidosis. And therefore, the strict preparation of patients with dietary restriction is recommended in order to suppress myocardial glucose uptake, so that the exact inflammatory site of the myocardium is identified. So patient preparation is a key for this test. Typically, patients are advised to do a low to no carbohydrate diet as well as a high fat diet, so that myocardial glucose uptake is suppressed. Prolonged fasting is recommended, and intravenous heparin administration about 15 to 30 minutes before injection of the FDG is also recommended. The idea is for the FDG to be taken up by macrophages and not the normal myocardium, so that the inflammatory sites can be highlighted. So I have 4 examples here reflecting different stages of cardiac sarcoidosis. This first panel shows resting perfusion study, which has normal perfusion. And then the top panel is FDG uptake. As you can see, FDG is mostly in the blood pool and not in the myocardium, suggesting that there is no perfusion abnormality and there is no abnormal metabolic activity in the myocardium. Therefore, this panel represents a normal study. In panel B, there is a subtle defect on perfusion images in the anterolateral wall, and correspondingly, there is increased uptake of FDG in the myocardium in the anterolateral wall, suggesting that this is active myocardium, active sarcoidosis or active inflammation. In panel C, there is evidence of anterolateral perfusion defect as well as anterior perfusion defect. When FDG images are seen, there is increased uptake in the anterolateral wall, subtle anterior perfusion defect suggesting that the anterolateral wall's area suggests active inflammation, whereas the anterior wall is probably a chronic sarcoidosis. So this pattern is called a mixed pattern. Whereas here, in the last panel, there is evidence of anteroseptal perfusion defect, as well as the inferior perfusion defect. However, on FDG imaging, there is no abnormal myocardial uptake that suggests that this is chronic and not active cardiac sarcoidosis with chronic scarring. However, certain things that need to be kept in mind while interpreting these studies is that myocardial glucose suppression is the key for performing or for getting good quality studies. And then FDG uptake by myocardium not necessarily indicates sarcoidosis, but in the right clinical context, and also once we exclude other conditions that cause myocardial inflammation, such as myocarditis, Chagas disease, all these should be excluded before we can confirm or before we can say that the diagnosis is cardiac sarcoidosis with high certainty. Also important is that while acquiring PET images to do a whole body scanning, that will enable us to identify any other sites of sarcoidosis, such as here, there is extensive hilar lymphadenopathy. This not only further confirms or further supports the diagnosis of sarcoidosis, but also would help us obtain a tissue that is more peripheral and less risky than endomyocardial biopsy for tissue diagnosis. Coronary artery disease has to be excluded in all these patients in the right clinical context. And also the burden of inflammation can be quantified with SUV metrics and also can be followed for assessment of response to therapy. So this is an image showing active sarcoidosis with evidence of uptake in the infraseptal as well as the anteroseptal walls. With treatment, 6 months of immunosuppressive therapy, most of the inflammation has resolved. So response to treatment can also be assessed using PET imaging. So in summary, echocardiography is a portable and widely available low-cost tool for screening patients with high clinical suspicion for any infiltrative cardiomyopathy. It not only does it provide assessment of systolic and diastolic dysfunction, but also provides subclinical assessment of myocardial mechanics, which may be an indicator for future adverse cardiovascular outcomes. Radionuclide imaging with bone-avid radio tracers has changed the way we approach diagnostic algorithm of TTR amyloidosis. And then PET metabolism and PET SPECT perfusion imaging enables a diagnosis of myocardial inflammation, scarring, and microvascular dysfunction, very helpful in the diagnosis of cardiac sarcoidosis. Serial studies also help us assess response to therapy by quantifying the intensity of myocardial uptake and the extent of the defects.
Wonderful. Thank you so much. That was a really great overview of echo and PET imaging and infiltrative cardiomyopathy. That was great. There are also some interesting questions coming in the chat, in the Q&A, I should say, regarding diastolic dysfunction and strain in infiltrative cardiomyopathy. We'll save those after the last talk here. So next we have Dr. Hanneman. I'm really excited to introduce Dr. Hanneman, who is the director of the Department of Medical Imaging at the University of Toronto. She'll talk to us today about cardiac MRI and infiltrative cardiomyopathies. Thank you, Dr. Hanneman.
Hi, everyone. Thank you so much for having me today, and of course for the invitation to be part of this really fantastic writing group, which I just want to highlight was such a wonderful process to be part of. I learned so much from everyone. I'm a multimodality imager, but my practice spans MR and CT and PET. And so really I had so much to learn about the echo part in particular, as well as the SPECT findings, which we just heard so elegantly about. So I have the perhaps difficult task of following those two fantastic talks, and I'm really trying to bring things home with focusing on the cardiac MRI findings mostly. And so I'll try to make the case that I think cardiac MRI has some unique strengths in the setting of infiltrative cardiomyopathies in particular. And so, of course, we often think about cardiac MRI as providing evaluation of structure and function of the heart. We can quantify ventricular size and function. We can look at strain and some more advanced parameters. But really, when we're thinking about infiltrative cardiomyopathies, the main value add, kind of the key piece of information that we often can't get from other imaging techniques or don't get as much detail on, is the ability to characterize the myocardial tissue. And so really that's a main strength. And we have several different techniques that we'll go through that can add value for us. And so when I think about cardiac MRI in answering questions about infiltrative cardiomyopathies, I think we can kind of think about this in terms of helping us to make a diagnosis. If one hasn't been identified already, perhaps the patient had an echo and there were some findings maybe suggestive of a particular underlying disease process, but patient might then go on to have cardiac MRI to further characterize those. You might do follow-up imaging to track changes over time, either as disease process is progressing, or ideally in response to therapy, where we can ideally track changes as patients improve over time. Of course, we also really are interested in looking at the ability to risk stratify patients and identify who might need closer monitoring or different therapies. And so the prognostic piece is also really important. So when we're thinking about cardiac MRI and tissue characterization, I always tell our trainees, really, we have this like fantastic toolbox at our disposal. And it's not kind of one technique versus the other, which is, sometimes how things get positioned in research papers or in research studies when we're thinking about making comparisons. But in real life practice, of course, we, often integrate findings from multiple techniques, so multiple sequences in terms of trying to understand what's going on. And as we heard about in the last talk very elegantly, that always has to be in the context of the clinical picture and findings from any other imaging tests that the patient might have. And so, we're not interpreting these in isolation. Really, we need to integrate all of the clinical and imaging findings together. And so, LGE really, of course, has been around for many decades, and we often think about this in terms of viability assessment in the setting of ischemic heart disease, but also has a really important role in the setting of non-ischemic cardiomyopathies, including infiltrative disease. I'm a huge fan of our parametric mapping techniques, and I'm going to try to highlight some of the key findings for those techniques, and they really can add value, especially when we're thinking about longitudinal changes, because not only are, of course, they're beautiful images, but they're also quantitative, and so that can be very powerful to track changes over time. So when we think about a protocol for infiltrative cardiomyopathies, this is kind of a standard protocol. Of course, you would ideally want to tailor it to your specific clinical question, but just to try to, show those of you who might not do cardiac MRI in your clinical practice how these pieces come together. Well, first we need to find the heart. So usually our technologists will do some localizer sequences. We always do native maps fairly early on, and so here's a patient who has a very thick ventricle that you can already see in the maps. We would administer contrast at this point, then we would move on to our CINEs, which are really important, again, for that quantification piece, looking at ventricular size and function, how thick the ventricle might be, really relevant in this particular disease process. And then, of course, after a delay, we would acquire LG images. And then, if you're going to calculate ECV, then you also need to do your post-contrast maps. So now let's take a little bit of a deeper dive into some of the specific diseases that we've already been very elegantly introduced to. So we heard, of course, cardiac amyloid is, really was previously underdiagnosed, and we now have increasing recognition of this in the heart, of course, most commonly light chain and ATTR. And so when we're thinking about our CINE imaging and what do the ventricles and atria look like, well, often we have concentric wall thickening. The atria are usually dilated in the setting of a restricted phenotype. Sometimes we'll have effusions, and often there will be biventricular dysfunction, particularly in later stages of disease. The LG imaging can be very dramatic, particularly in later stages of disease, and we'll show you an example of that, but just a reminder that this exists on a spectrum. And so, just if you have a CMR exam in front of you and it doesn't meet all of those kind of very slam dunk classic criteria for LG, don't be dissuaded from thinking about amyloid. If patients are presenting earlier, which is, of course, ideally when we would want to diagnose them, sometimes the findings can be more subtle. And then our maps, including native T1 and ECV, can really be very helpful in picking up earlier changes. Typically, both native T1 and ECV are elevated. They can be quite dramatically elevated, and that's related to that extracellular expansion due to the amyloid fibrils. And so in this case, those elevated values aren't reflecting fibrosis, which they are in many other diseases, but here really they're actually telling us and allowing us to actually measure that amyloid deposition. ECV is also really a robust marker for prognosis. So the higher it is, the worse patient's prognosis, but also can be used to track changes in relation to treatment, which of course we fortunately have, such amazing developments in terms of treatment options for these patients who really before had very poor prognosis. So here's again a very kind of classic, but more end stage or later stage rather, cardiac amyloid phenotype on cardiac MRI. So, this dark blood pool, very difficulty knowing the myocardium, classic story where your technologist will call you and say, I can't find an appropriate inversion time to null the myocardium. Nothing looks normal here. And so when you see that, you really want to think about amyloid. classically will have, again, very high native T1 and ACV, and that is telling us about that expansion of the extracellular space. But again, just another reminder that these numbers depend on your field strength. So here, these are at 3T, that's why our native T1 is so high, and really need to be interpreted in the setting of a normal reference range, as well as in the clinical context. Fabry disease, we heard about the beautiful echocardiographic findings, and this is the disease that's really important to me. We have a large Fabry clinic in Toronto, and we've done some research on this, particularly MRI findings. And so, you know, often these patients in the past were misdiagnosed as having circumferential or concentric HCM. Even when we did a genotype-phenotype study in our own center, you know, there was a number of patients who were picked up, had been followed for many years in HCM clinic, but were gene positive for Fabry disease. And of course, these patients have completely different treatment and trajectory and implications for family screening. So you do really want to think about this when you see that kind of circumferential wall thickening, particularly in a male patient, and with a classic pattern of LG at that basal infralateral wall. In these patients, native T1 mapping really has such an important role. So unlike fibrosis and amyloid, where T1 is elevated, in fat and glycosphingolipids, T1 is driven lower. And so it's going the opposite direction that we would expect it to go in HCM, for example. And so that can be really powerful to try to pick up these patients. LGE in this disease process also is prognostic, and so that's really important to look for it and identify it and communicate that clearly in our cardiac MRI reports. There's also some beautiful data about the role of inflammation in these patients, and I'll show that in our next case. But this is a patient who has, you know, earlier Fabry cardiomyopathy, and you might say, well, that left ventricle isn't thick at all. And often, actually, we'll see this in women who have Fabry disease, despite the fact that it's an X-linked disease. Women often do manifest disease manifestations, although often a milder form and later in life compared to men. And they often will develop LGE even before the left ventricle is thickened. So if you're, you know, only screening patients with echo, for example, and looking for the left ventricle to get thick, you might actually miss some of these patients who already have fibrosis, again, particularly women, and that's really important from a sex-specific disease perspective. And so here, you know, much more subtle LG at that infralateral wall, our native T1 is very low, and that is actually telling us about the glycosphingolipids in the myocardium. And native T2 can tell us about elevation. And there is some research to suggest that actually that inflammatory process might be driving the fibrosis eventually in that location. And so these are fairly classic findings, although a milder phenotype. Here's a beautiful figure showing us the correspondence of MRI and PET findings. So this is FDG after diet suppression, so similar to the sarcoidosis protocol that we heard about from Dr. Kottam earlier, where you can see that there's co-localization of focal FDG uptake along with that area of LGE, again, showing us that there is an inflammatory component that may be driving the fibrosis that we eventually see at that basal infralateral wall here in a patient who has more severe phenotype. Cardiac sarcoidosis is also a really important disease, of course, to diagnose, and we want to use imaging to track changes over time. And we heard beautifully about how you can use SPECT or perfusion imaging, as well as the inflammatory imaging with FDG, to try to put those two different pieces of information together and co-localize them and try to understand what's happening in the underlying myocardium. And so cardiac MRI also plays a really important role in this, and LGE is often present in patients who have cardiac sarcoidosis, often nodular or patchy, can be mid-wall, sometimes subepicardial, can be confused from myocarditis even, or even left dominant arrhythmogenic cardiomyopathy. And if you see this pattern where the LGE extends from the interventricular septum into the anterior wall, this has been described as a hook sign. And if you see that, you definitely want to think about sarcoid. Definitely can see it in other diseases, but you know, something that has been described in this disease process. Often we will see high T2 either on our T2 weighted imaging or T2 maps, and this should co-localize with areas of focal FDG uptake. One of the reasons that cardiac MRI is really powerful is that it can give us information about both chronic and active disease. So LGE can reflect both phases of the disease. Of course, T2 is usually specific for edema and inflammation, although we have found that it's slightly less specific than focal FDG uptake. And so here, I love combined PET MRI, and really cardiac MRI, cardiac sarcoidosis rather, is like a perfect use case for when co-localization can give you information about what's going on. And as you can see here, well, we have this classic nodular midwall LGE at the interwall. We do see high T2 in this case because this was such active disease. And on our focal, on our combined, our fused PET MRI image, you can see that there is focal FDG uptake, again, telling us that not only is there myocardial injury here, but there's active inflammation. And the PET really is so important for tracking treatment changes over time and is much more useful for that. Once you have LGE, it largely stays there. And so not the best technique for tracking changes over time. And iron overload, cardiac MRI really plays an important role. Traditionally, this was with T2 star assessment, and an incredible body of work, largely driven by groups in London who really pioneered this and showed that this corresponds to myocardial iron. But we also know that iron will cause T1 to go lower, and there's some beautiful data that's emerged that show that native T1 might actually be more reproducible. We've yet to convince our clinicians who follow these patients within our large iron overload clinic at Toronto General Hospital, to use native T1, they still rely on T2 star because there is such a large body of literature to support that. But we follow both of them over time and are very sensitive to changes in chelation or iron overload. So here's an example of a patient who had no fibrosis at this time, although they can develop it. Native T1 and T2 star were both very low. So again, these go in the same direction, and both are very low. And here this was quite dramatic lowering of both of them. And finally, I just want to highlight the role of cardiac MRI in identifying some unusual diseases. And Danon disease is, something, again, that might be misdiagnosed as HCM, often have very thick ventricles. This is another inherited disease, often accompanied by other extracardiac findings, including skeletal muscle issues and learning disabilities, but not always. And one of the classic features, and I'll show you an example of this, is extensive LGE, which might look like any other end-stage, hypertrophic cardiomyopathy. But here it typically spares the septum, and it's kind of a classic picture. So once you see it, you really want to think about this. And if you're not sure, of course, you would recommend that the patient have genetic testing. Other diseases like Friedreich ataxia, which is an autosomal recessive disorder that can result in iron metabolism dysregulation. And so again, our mapping techniques might be very useful for trying to understand what's going on at the tissue level. Here's that example of Danon disease. And again, very, very thick ventricle. We can see that there is nearly circumferential midwall LGE, but that classic sparing of the interventricular septum, which is very much not typical for HCM, particularly in the asymmetric septal phenotype. And so if you see that, you really want to think about what else might be going on. And we can see here that native T1 and T2 are also elevated, again, telling us that there's probably an inflammatory component as well. And so in summary, hopefully I've showed you a couple examples of infiltrative cardiomyopathies and convinced you hopefully that cardiac MRI really does play a role. And I know this is often not our first line imaging test. Definitely, resource allocation and even access and wait times are absolutely challenges. But in select patients where one, the diagnosis might not be established, two, to risk stratify patients or provide information on prognosis, and finally to follow changes over time, particularly in relation to treatment, I think cardiac MRI really can add incremental value. And with that, I'll stop and thank you so much.
Thank you very much, Dr. Hanneman. That was fabulous talk, and we already learned a lot how we can see through the disease through the lens of the magnet. That was great. Obviously, we learned a lot this evening or this morning in the Australian time, and through the all three speakers. So, in the interest of time, I'd like to move to the Q&A sessions. So we've got some questions, and the first question is probably to the Dr. Kottam and Dr. Garcia. I think this is very important questions from the Dr. Sebastian Garcia Zamora. If you suspect infiltrative cardiomyopathy in echocardiography, however, find the EA ratio less than 1, would you reject the suspicion of infiltrative cardiomyopathy or not? Could I get some comment from both of you?
So I'll take this question. If the E and A ratio is reversed, that does not necessarily rule out infiltrative cardiomyopathy, because again, the diastolic dysfunction in infiltrative cardiomyopathy is a spectrum ranging from mild to significant or severe diastolic dysfunction. So E to A reversal may indicate early diastolic dysfunction in these patients or the early stages of disease. Particularly in patients with Fabry cardiomyopathy, it's known that the diastolic dysfunction rarely ever reaches the severe category. Most of the time, it tends to be mild. So in addition to evaluating diastolic dysfunction, it is also recommended that we take into consideration all the other kind of possibilities and also the clinical picture.
Great. Could we get some comment from Dr. Garcia as well?
Sure. No, in my experience, it varies depending on the type of infiltrative disorder. I would say it's a little bit uncommon with amyloid and with other cardiomyopathies that have a very small left ventricular cavity and increased wall thickness, because the only way that you can actually preserve your cardiac output is by kind of maintaining those high filling pressures. It's not impossible, however, and typically if you see, usually the patient has been aggressively diuresed, but you still have a abnormal E to E prime ratio. So even though your EA may be reversed, the E prime is exceedingly low and your EE prime remains quite abnormal. So it is frequently seen, I found, in patients with sarcoid and with other conditions that have a dilated morphology.
Great. Thank you very much. I think that's very great answer. So the second question is probably to the Dr. Kottam again. This is from the anonymous attendees, which is also, we respect that. So does the bone scintigraphy have any role in AL amyloid, or is it only specific for the ATTR?
So bone scintigraphy, the idea behind bone scintigraphy is that, or the proposed theory is that the bone avid radiotracers bind to microcalcifications within the TTR molecule. Calcium is found more often in TTR molecules than AL, but sometimes in certain AL cases, we do see some retention of radiotracer in this. Most of the time, the radiotracer heart to contralateral ratio is equivocal in the equivocal range, but sometimes they can be more than or equal to grade 2. So it can happen, and like I said, about 25% of cases of AL amyloidosis PYP scan can be equivocal, or there would be myocardial uptake. So that is why ruling out AL amyloidosis by checking serum light chains and electrophoresis is extremely important.
And that sounds great. Yeah, agreed. And also at the last slide of the Dr. Garcia's presentation, we saw the figure 7 of this document. This is the suggested diagnostic algorithm, and there's a beautiful flow chart, and it contains both of them. Thank you very much, Dr. Kottam. I will pass it to you, Jiwon.
Great. We have some really interesting questions here in the Q&A. The next one I want to ask, I'll try to summarize this a little bit, has to do with strain in amyloidosis. And this is a question that comes up for me as somebody who also spends time in echo. What is the specificity of the apical sparing pattern in amyloidosis? There are now papers describing that maybe it's not as specific. What are some conditions that you're seeing this pattern in? And is there a role for GLS, at this point, given maybe, not the perfect specificity? I think this would be a question for Drs. Kottam and Dr. Garcia again.
Dr. Garcia, would you like to answer this? I can. You're muted.
Yeah, that's a loaded question. But if you actually look at the original paper that describe this pattern by Phelan and the Cleveland Clinic group, you could see that the control group, which were patients with hypertensive, also have higher strain in the apex that at the base. I think it's a magnitude of the difference that when it's very striking, when you see really that red cherry on the top pattern with very, very low velocities at the base, it's more specific. I couldn't quote you a number, but I think it depends on the magnitude of the difference between the apex and the base. So I still think it's useful.
In my clinical experience as well, that's what I have seen, that if it's a classical cherry on top pattern, then it is likely that patient has amyloidosis. However, in certain conditions like hypertensive heart disease, or also in some patients with end-stage renal disease, we see attenuation of basal strain values. They raise a suspicion for TTR amyloidosis, but often in our testing, it turns out to be normal, negative study. So I think if it is classic, then it is highly likely that it is reflective of TTR amyloidosis or amyloidosis, but some variations can happen as well.
Great, thank you for that. I think that was really clear. So if it's classic, then that can be very, very specific in terms of the pattern. We have a question for Dr. Hanneman here. Is there any diagnostic advantage for infiltrative cardiomyopathy using a 3 Tesla versus a 1.5 Tesla field strength scanner?
It's a great question, and thank you for that. So of course, at 3T, we have higher signal to noise, and that can provide some advantages, particularly for MRA, for example. But that also comes with some artifacts, of course, particularly in the CNS-SFPs. And so, I think from an infiltrative cardiomyopathy perspective, it's a bit of a wash, but really just to caution everyone about interpreting the parametric maps, in the context of a local reference range. I think most centers globally would prefer 1.5T for cardiac MRI in general, but just acknowledging that, yes, of course, there is definitely higher signal in terms of higher field strength.
Great, thank you. And I think this may be the last question here. Is there any typical imaging pattern on CMR specifically with hydroxychloroquine restrictive cardiomyopathy? Some case reports mention intramyocardial patchy LGE pattern.
I'm happy to answer that. So, we've looked at that at our center as well. Of course, relatively rare disease, though probably underdiagnosed. So thank you for that excellent question. So interestingly, if you look at the histopathology of these patients, it actually mimics Fabry cardiomyopathy. And basically what's thought to happen at the pathophysiologic level is that it's actually inducing a lysosomal storage disorder. And so it makes sense that we often will see basal infralateral LGE first, often in the setting of quite marked wall thickening. So often that comes first. Usually patients have impaired function, unlike Fabry cardiomyopathy, which we only typically see later. And then often we will see areas of edema as well. So it can be quite extensive and typically will progress even after patients stop their antimalarials. And that's thought to be related to stores within the body, but also kind of this triggering of an inflammatory response that seems to, become dysregulated, basically.
Wonderful, thank you. Really interesting pathology. Fantastic. Well, thank you so much to everybody. Thank you to all of our speakers. Thank you to all the attendees. I think we all learned quite a bit today. Thank you for joining us. And I hope that you'll join us for our next event as well. Thanks, everybody.
Thanks, everyone.
Thanks, everyone.